Good morning. I am thrilled to be here today to be talking about wellness and in particular about brain health. So today we're going to be covering what you can do today to protect your brain for tomorrow. I am Rachel Whitmer. I am professor and vice chair of research in the departments of public health sciences and neurology, and I am also the director of the UC Davis Alzheimer's Disease Research Center. So our center's vision is a lifetime of brain health for all. And I really hope today that one of the pearls that you come away with is that you have to think about your brain over your lifetime and not just late in life, where we may commonly see symptoms of cognitive changes. The brain is with us our whole life, and much in the same way that you think about taking care of your heart, I want you to think about taking care of your brain over your lifetime. So our goal is to advance the science of healthy brain aging in diverse populations while caring for those who are affected. And how do we go about advancing the science of healthy brain aging? Well, we know that cognitive decline and dementia are complexly determined by multiple disease-related pathways. But these pathways can be buffered by protective factors which promote resilience. And so when I'm talking about cognitive decline and dementia, the opposite of it, of course, is brain health. And so the research today that I'm going to be covering with you will give you an idea of how to not only lower your risk of cognitive decline and dementia, but also how to promote brain health and raise your chances that you have exceptional cognitive function late in life. As a reminder, there are people living with dementia around the world, and the latest projections show that by 2050, we are going to have over 131 million cases. So there has never been a more important time to think about brain health wellness and to not wait until late life to think about it, but to start thinking about it from the time of childhood through young adulthood and through midlife. So I've been using the term dementia. So when I say dementia, what does that mean? Dementia is an umbrella term that refers to a syndrome, and under that umbrella are different causes of dementia. I'm sure you've heard of Alzheimer's disease, which is the most common subtype of the syndrome of dementia and is characterized by neurodegenerative processes. The second most common type of dementia is vascular dementia, and that refers to vascular brain injury, such as stroke. The truth is that most people who are diagnosed with some type of severe cognitive impairment or dementia actually have mixed. If you get the opportunity to do brain imaging or look at someone's brain, most people have evidence of both neurodegenerative and vascular pathways. And that's important to know, because when we think about ways to lower our risk and promote our resilience to dementia or cognitive impairment and increase our brain health, we need to understand that there are both things we can do that affect neurodegenerative changes as well as the vascular health of the brain. We're going to be talking today a bit about certain groups that are at higher or lower risk of dementia. And at our center and in our work, we take a disparities framework. So when we're looking and following people and trying to understand why some groups might be at higher or lower risk, we take into account environmental, sociocultural, behavioral, and biological risk factors. And we not only take them into account, we think about them over the life course and not just in late life. So when we're thinking about who is at highest risk for Alzheimer's disease and related dementia, we try to think about who are these groups and how well are they represented in our research. So we know that there are certain racial and ethnic groups that seem to be at higher risk, and we'll be talking about those in a few moments. But we also know that people from rural populations and those from socioeconomically disadvantaged backgrounds also are at higher risk. And we also know that those who have low levels of formal education are also at higher risk. So when I use the term health disparities, it is the unequal distribution of health and illness due to unfair economic arrangements, poor social policies, and bad politics. And what that means basically is that when we see differences in rates of cognitive decline or in rates of dementia across different groups, we are not saying that it is due to something that's intrinsic to the biology of these groups, but rather it is the result of a health disparity, which means that it is due to poor social policies. It's not caused by differences in genetics or variation in other health and risk factors. There was a very important paper that was published in 2016. And this paper looked at almost 13 years of follow-up in Kaiser Permanente, Northern California plan members. Kaiser is an integrated healthcare delivery plan. And this study looked at electronic medical records and captured incident cases of dementia over almost 13 years. And incident means the very first time. So first diagnoses of dementia. And this study in particular looked at rates of dementia across 6 different racial ethnic groups. And even though this study was published in 2016, this was the first time that anyone had looked comprehensively at the rates of dementia in some of these groups. One of these groups was Asian American, which of course is a very heterogeneous group, a huge part of the population, a very big part of the population here in Northern California, and we didn't even have basic information on the epidemiology, on the rate of dementia in this group. This study, coming out of Kaiser Northern California, showed that those who identify as African American or Black had a higher incidence rate of dementia, and those who identified as non-Hispanic, white, or Latino had a similar rate, and those who identified as Asian American had the lowest rate. And again, this is over 12 years. This study also included a large group of those who identify as American Indian or Alaska Native, and they also had a higher rate of dementia in comparison to non-Hispanic whites. Again, this study was following people up to almost 13 years. In Kaiser members age 65 plus, and the study included 274,000 people. So in 2016, this was actually the first time that systematically rates of dementia had been looked at across these different racial ethnic groups. And it was the first time that one looked at Asian Americans and those who identify as American Indian and Alaska Native. So I talked a couple moments ago about a disparity, and this is an example of a health disparity. We're seeing different rates across racial ethnic groups in people who are members of the same health plan and who have the same access to care. So that implies that there is something going on that have to do with sociocultural factors that could possibly be elevating risk. What do we know about what happens over the life course and brain health and dementia risk and resilience? And when does the clock start? And we're going to be talking today about timing of different vascular and behavioral and contextual risk and protective factors. So in our work, we really try to understand when is the threshold set, We know that changes in the brain accumulate over many decades. So even though this is something that typically shows up late in life, most people are diagnosed with dementia at an average age of about 80 or 81. We know that the changes in the brain are happening over 1, 2, maybe even 3 decades. So when we're looking at risk factors, it's important to not only look at groups of people late in life, but to also look at people earlier in the life course. There was a paper published in 2005, which we led, looking at high body mass index in midlife. And these people were between the ages of 40 and 55. And those who were obese had a 74% greater risk of dementia, even taking into account other risk factors and other diseases that are commonly associated with being obese, such as hypertension, stroke, diabetes, heart disease, and hyperlipidemia. So even after we take all of those things into account, we still see this very robust association between being obese in midlife, and we also see an elevated risk of dementia associated with being overweight. And in this study, we were looking at obesity and overweight from the 1960s and the 1970s, before we had the obesity epidemic. So this is really important information about how a risk factor early in life, in midlife, is associated with an elevated risk many decades later. And so this is one thing to think about in terms of brain health and wellness, is trying to avoid obesity. We also know that heavy smoking increases long-term risk of dementia. And this is something that was somewhat tricky to study initially, because people who smoke a lot tend to not live as long and may not live to an age where they would be at risk for dementia. But in our study, we had enough people who were heavy smokers, smoking 2 or more packs a day, and they had almost a double risk of dementia compared to those who never smoke. So again, if you're thinking about smoking, or if you are a smoker, another reason to quit would be to increase your brain health. There was a wonderful midlife dementia risk score that came out of Finland called the CADE risk score, which is a combination of looking at age, education, high cholesterol, body mass index, and high blood pressure, hypertension. And you can actually add up these items and calculate your 40-year risk of dementia. And this study came out of Finland, so a very different place from the US, but I'm happy to say that it was replicated in Kaiser Permanente, Northern California, and it replicated really well in a very diverse group of people. And so basically, this combination of modifiable risk factors in midlife has a long-term impact on your risk of dementia 30 to 40 years later. There's been some really important work that has looked at where people are born. And in our study, we have a large number of people who, though they were living in Northern California by midlife, they were born in the stroke belt. And these people, even though they left the stroke belt and lived in Northern California by the 1960s and 1970s, birth in a stroke belt was very robustly associated with an elevated risk of dementia. And this was even taking into account vascular risk factors, both in midlife and late life. And we don't know the exact reason why we see this association, but our hypotheses seem to include perhaps early exposures to environmental factors, different quality in education and schooling. And we know that education and quality of education protects the brain. And so this really speaks to the fact that there can be a long-term impact. So again, when we're thinking about brain health, we need to think about it over the life course, even starting with where you may have been born. So So I spoke before about these marked differences across racial ethnic groups in risk of dementia, and I want to spend a few moments talking about type 2 diabetes, which is something that we are also experiencing an epidemic. There's been a steadfast increase in type 2 diabetes, and this is a major public health issue, which will continue to impact brain health. So I want to talk about, what do you do if you have diabetes? What can you do to increase your brain health and lower your risk of dementia? We know from epidemiological studies that individuals with either type 2 or type 1 are at an elevated risk of dementia. There's been a lot of work looking at glycemic control. So when you have diabetes, your goal is to control your blood sugar. And there's been a lot of work showing that those who are less controlled, who may have a glycosylated hemoglobin above 8% over a long time period, are at a higher risk of dementia. So if you do have diabetes, this is another reason, in addition to trying to avoid complications of diabetes, this is another reason to think about appropriate glycemic control. We also know that individuals with diabetes who have very low glycosylated hemoglobin, so those who have values under 5%, are also at an elevated risk. And we know that these people are at a higher risk of very acute low blood sugar episodes, such as hypoglycemic episodes. So again, thinking about brain health, glycemic control matters. And the bottom line is people who've had severe episodes of hypoglycemia or hyperglycemia are at higher risk. So in summary, if you have diabetes, it's really important to have appropriate glycemic or blood sugar control and to try to avoid severe hypo, which is low, or hyper, which is high, blood sugar episodes, and to try to avoid the onset of microvascular, which is small blood vessel complications. And in doing that, you can improve your brain health and lower the elevated risk that we see of dementia associated with diabetes. So in protecting your brain with diabetes, we know that you need to try to prevent complications, try to avoid acute glycemic events, have appropriate glycemic control, and if you have depression, to seek treatment. Depression is a risk factor for dementia, particularly if you've had depression over the life course. And those with diabetes are also more likely to have depression. So we talked a bit about what happens if you have a chronic disease. We talked about the role of early life exposures, but let's talk about young adulthood. So for some people, cardiovascular risk factors are present even before midlife. And so people can have hypertension or hyperlipidemia. They may be overweight or obese starting in young adulthood, sometimes even in adolescence. What does this mean for brain health? Well, we have done some work which showed that those who had hypertension at time of adolescence or even young adulthood have worse cognitive functioning in late life. And we are continuing to follow these people to understand the association between young adulthood and adolescent hypertension and late life risk of dementia. But we know that these things are not good for brain health. Very interestingly, we've also been looking among those who are in their 90s. So we have been looking at people who make it to age 90, who start off without any type of cognitive problems, and following them over time. And what's been so exciting is that there's a group of people in our study who not only don't have dementia and don't have cognitive impairment, but they actually have what we're calling exceptional cognitive aging. So these people have memory and thinking skills that is not only not dementia, but is also the same as someone who would be in their 50s or their 60s. So their brain, their cognitive function in their 90s is functioning like someone in their 50s and their 60s. And this is a really exciting avenue of research and science with big implications for brain health. Because of course, you want to avoid dementia or cognitive impairment, but wouldn't it be nice if we could take it a step further? And not only did you not have cognitive impairment, but you had exceptional longevity, and you lived to your 90s, and your brain was functioning like that of someone in their 50s and their 60s. So we've identified these people, and we're now going back and looking at what was it about their lifestyle, and what is it about their set of risk and protective factors that have set them up to have exceptional cognitive functioning. A really important piece of work came out July 31st, just a few days ago, July 31st, 2024. And it's called Dementia Prevention, Intervention, and Care, 2024 report, the Lancet Standing Commission. And you can see here on this graphic that this is a report that took into account analyzing all of the risk and protective factors that we know across different populations and trying to answer the question about if you took away these risk factors, how much dementia could you actually prevent or could you actually delay? And you can see here that they broke down these risk factors by life course. So for early life, we see less education is a risk factor. And that is something that is very consistent and very well known. And there's also been some more recent work looking at quality of education. When we jump to midlife, you can see here hearing loss, high, low density lipid cholesterol, depression, traumatic brain injury, physical activity, diabetes, smoking, hypertension, obesity, and excessive alcohol consumption. So this is in midlife. These are the risk factors. In late life, what are the things that elevate one's risk of dementia? Social isolation, exposure to air pollution, and vision loss. And the metrics that were done in this very large-scale and in-depth work was understanding the scope, extent, and scale of these risk factors across different populations. So understanding these risk factors, but also how prevalent are they? And the calculation that they came away with is that taking into account these 14 risk factors, 45% of dementia is potentially modifiable. So that is almost half. So that's saying half of your risk is modifiable, because these things that we are looking at are things that are modifiable and that one might be able to change. What's really important with this Lancet Commission, as compared to 4 years ago when the last one came out, is the two new risk factors that have been identified. High, low density lipid cholesterol in midlife is a new risk factor, and vision loss in late life. And so these are new things, and these are new things that we need to think about. So from a public health standpoint, when you're thinking about brain health and thinking about where are you on the continuum of life course, what are things that you can do to protect your brain, increase your brain health, and lower your risk? And so I highly recommend that you refer to this graphic and think about all of these items and if there's something that you can change. So the key points from the Lancet Commission is that 45% of global dementia is attributable to these 14 factors: less education, hearing loss, vision loss, hypertension, smoking, obesity, depression, physical inactivity, diabetes, excessive alcohol consumption, traumatic brain injury, air pollution, social isolation, and high, low-density lipid cholesterol. And so I want to also make a note that diet could also be an important factor in addition to these these 14 factors. And diet is a big part of different multi-domain lifestyle trials that are going on right now that are associated with cognitive function and cognitive decline. But it was something that this commission didn't have the opportunity to look at. But we'll be speaking in a few moments about some of the other studies that have been looking at diet. From a public health standpoint, one needs to be thinking about risk reduction and not just thinking about one thing, but about multiple things. And again, thinking about it over the life course. So some of the recommendations from this are that from a health policy perspective, to try to ensure that high quality education is available for all, but also to encourage cognitively stimulating activities, to make hearing aids accessible for people with hearing loss, and to try to decrease and understand the role of harmful noise exposures on brain health, to treat depression, to encourage the use of helmets and head protection, to encourage exercise, to reduce cigarette smoking, and to prevent or even reduce hypertension and maintain appropriate blood pressure. So how do we think about changing risk factors, and how does it have an impact on brain health and risk of cognitive impairment or dementia or Alzheimer's disease and related dementias? We've been talking about risk factors that elevate one's risk. But what happens if you are already having some cognitive changes? So again, as I spoke about earlier in the talk, remember that dementia develops over many decades, and it's due to many different factors. So the implication for that is that our treatment and our preventative mechanisms need to really start early, ideally before symptoms of cognitive changes happen. And as a reminder, most people with dementia have evidence of mixed pathology. And what I mean by that is that there's evidence of both neurodegenerative changes as well as vascular injury. So when we're thinking about prevention, we can't think about just one thing, because we know that there's a multitude of many different things happening in the brain that cause someone to show symptoms of cognitive changes. I'm going to speak for a few moments about something called the FINGER study, which stands for the Finnish Geriatric Intervention Study to Prevent Cognitive Impairment and Disability. This was a 2-year multi-center study in older adults in Finland, ages 60 to 77. And one of the groups in the study received training and additional support. So everyone in the study was provided information on diet, exercise, cognitive training, and appropriate control of their vascular risk factors. But another group received additional training and support. This study followed people over 2 years, and the group that received the additional training and support had less cognitive decline compared to the group that did not. And so what was so exciting about this is the first time that there was a multi-domain, meaning not just one thing. We didn't just look at diet or just blood pressure. A number of things were changed. And it's the first time that it was seen that having a true lifestyle intervention that involves different things is good for the brain and is associated with less cognitive decline. Equally exciting is that the study's over, but the people continue to be followed. And the people in that intervention group who received more support to make these changes are at much lower risk of incident, meaning new, chronic disease. So this study has been over for a number of years, and there continues to be a benefit. There continues to be a legacy effect of this lifestyle intervention. At the end of the intervention, body mass index was better in the In the intervention group, diet habits were better, physical activity was higher, and very excitingly, they had a 30% lower risk of changes in their activities of daily living. Activities of daily living is things that you do every day to be independent and take care of yourself. So even after the study was over, there not only was an immediate effect on brain health in terms of less cognitive changes, but also longer term, the group was at lower risk for chronic disease and had better activities of daily living. There's a very exciting study going on right now, and UC Davis is one of the sites, called US Pointer. And this study is to replicate this finger study, to adapt this finger lifestyle intervention to fit into our culture here, and see if we can identify an infrastructure that could support a sustainable brain health lifestyle program. So in the US Pointer study, we have two groups. We have a self-guided lifestyle intervention, which is group meetings 2 to 3 times a year to provide resources and information, and guideline-based health planning, so an annual physical exam and blood test. We have another group that has a very structured lifestyle intervention. Exercise 4 times a week, the MIND diet, which is a combination of the Mediterranean diet and the DASH diet, cognitive stimulation, and also having a group of other people going through these changes as well, so having your own team, and a guideline-based health coaching. What's wonderful about this US Pointer study is here at UC Davis, we are one of 5 sites, but US Pointer is just one of a number of other lifestyle intervention studies that are happening right now around the globe. And this is called Worldwide Fingers. And so this is a network of multiple domain, meaning many different things, a full lifestyle intervention change, following people around the world and looking at their cognitive function at the end, their brain health, and their risk for dementia. Back to the original study that this all was based on, the original finger trial showed not only a really nice effect of those who were in that more structured intervention group, but they also analyzed those who were in that group. What was their level of participation? And if you participated the most, you tended over time to have even better result on your brain health. So that group that had the more structured intervention had better brain health, which was less cognitive decline compared to the other group. But even within that group of the structured intervention, the amount that you participated, the amount that you did, the amount that you changed your lifestyle was associated with how much it benefited your cognitive function and your brain health. So as a reminder, all of these lifestyle things are wonderful things to think about, lowering your risk for dementia or cognitive impairment and improving your brain health. And also as a reminder, if we can even delay onset of dementia, we would expect to save millions and millions of people. So for example, if we delayed onset of dementia by 5 years, we could avoid over 5 million people not expected to get dementia. So in summary and as a reminder, there are many ways to improve one's brain health and to lower risk. And these are things to think about over the life course. Brain health is a lifetime mission. Thank you.